We like to stick to 20% because that is more like it, and more towards the real mortality. And if you look at the main causes, the underlying infections on the main causes, and if you look at the sepsis being the main cause, it's increasing mortality by almost 16 times. And if it's uncontrolled infection, almost 22 times rise in the mortality rate. Okay. The fistula location is again important, because the more distal the fistula, the less the mortality. And that's why you have mortality rate of 29% with the jejunal fistula, and with the colonic it's almost 6%, right? The output again makes a difference, and if you got a high output, the mortality is in the range of 52%, and you got a low output in the range of 26%. There could be other causes, like for example, other comorbidity is existing, but that is not directly related to the fistula problem, but then they are there, they could be responsible for the mortality. And of course, one very important factor is whether that patient with the ECF or EMF is being treated, EAF is being treated either in a trained unit, a unit which is basically geared up to treat such patients, or it's just a general surgical unit. Now look at the difference in mortality, almost twice. The general surgical unit, the mortality is almost 42%, and a trained unit only 20%, right? So half, almost 50% change in the difference in the mortality, right? Now, right. If you look at the classification could be an anatomic classification, physiological classification, or it could basically an ecological classification. The anatomical classification basically deals with the site from where the fistula has formed. If it's proximal, we're talking about the stomach, the duodenum, the high jejunum. Distal, we're basically the distal jejunal, the ileal, and the colonic. Physiologically speaking, it basically depends upon the volume of the output, and is being graded as a high output and low output. You'll be encountering this term fairly commonly throughout the discussion of enterocutaneous fistula, not only here but in any of the books that you choose to refer to. So you have a high output, a low output. Now basically you would find that this has got a slightly varied definition. There are books which say high output should be considered when the amount of output is more than 1 liter or 2 liters. But we'll follow the most commonly stuck to definition, that high output should be any effluent volume more than 500 ml per day, and low output 200 ml per day, and anything in between you have the moderate. If you look at the figures, almost half of them are low output, and the rest half are basically the high output plus the moderate output. The figures 49, 51%. If you look at the etiology, look, why did I say that is basically surgeon made? Because iatrogenic 75%. That's why we can recognize the surgeon made. And 50% of these 75% are post-anastomotic, and 25% are basically inadvertent. There's an unrecognized enterotomy, let's say after adhesiolysis, or you're doing a ventral hernia closure, or doing abdominal closure per se, you're stitching the wall and you take a bite in your needle, and that comes and sticks, and later on it forms a fistula. So that is basically an iatrogenic cause. Spontaneous, which are secondary to malignant radiation, inflammatory bowel disease, diverticular. So this is basically those conditions where they form by themselves. The surgeon is not responsible, or it could be traumatic. So together, spontaneous and traumatic, they account for almost 25% of the causes. If we look at the iatrogenic causes, the stomach, what we are basically responsible for may not be responsible. The reasons may be responsible, but then these are where the surgeon has entered into the arena. Like for example, you have done a repair of the duodenal perforation, or you have repaired a gastric perforation. Fairly common scenarios where often you find a leakage, and your drain starts leaking with bilious or greenish fluid. And you can't understand what's happening. Now you know that yes, there has been a leak somewhere, right? Or post-gastrectomy. In the colon, again, you have anastomosis done with the colocolic or ileocolic, it leaks. Basically, either because of technical problems, or because there has been a disease like inflammatory bowel disease or malignancy where you're doing anastomosis and it is led to perforation, right? So either the disease per se or a technical problem in such disease, right? A pericolic abscess formation, like for example diverticulosis, tension of the suture line, a very common, I wouldn't say a very common, but yes, it's a common cause where there's ischemia of the suture line. We already talked about yesterday that you can have a denudation of the bowel of its mesentery, maximum sustainable 3 cm small bowel and 2 cm for the colon. If you have any other damage to the mesentery leading to ischemia further down beyond 3 cm or 2 cm in the colon or the small bowel respectively, then you start having ischemic problems, and you basically have a leakage, right? Post appendectomy, again, cause where you have a perforation at the base, you have tied it off, but the tying is such that the perforation or the perforated part has not been completely isolated. So better would be in these cases take a transfixation suture. Or you have drained appendicular abscess, it is bound to happen. Just drain the abscess and the fecal fistula develops or anterior fistula develops for a varying period of time. But one thing which is very important is in any emergency situation, be sure of one thing: the longer the patient is on vasopressor support, the commoner the occurrence of a ECF. The longer. That's why what we said is basically it stands to reason. Why? Because vasopressor support basically means what? That the blood pressure and the cardiovascular parameters of a particular patient are not stabilized. Basically, if they are not stabilized, what's going to happen? Ischemia everywhere, including the most populated circulation. I would say. Why? Because you have it is kind of a watershed of circulation. You have the whole bowel and the artery and venous, they undergo constriction. So basically what's happening out there is ischemia to the bowel. Now, there are certain prognostic factors which can basically tell you what's going to happen in the long run. If you look at these factors, you can actually prognosticate that particular patient. Like, for example, if you have a nutritional deplete, the patient's nutrition is near normal. So then you can say it's a favorable condition. Albumin more than 3. You have a low transferrin level, the patient is unfavorable, a low transferrin level, right? You have an intestinal continuity maintained, that means with a ECF, the patient is still passing some amount of flatus and feces. Or the patient got a low output fistula, a diverticular fistula, where it's come from a diverticulosis. These are very small fistulas, or there's a very small defect, partial bowel disruption, a long fistula tract, as opposed to a short tract, multiple tracts, and complex fistulas. These are all basically areas where you'll have unfavorable outcome. Prior radiation, again unfavorable outcome. Comorbidity. Index operation performed at the same center, you have a favorable output. You get a patient referred from some other center, you don't know what's really happened. The patient has come to you only with the ECF. The prognostication of this patient is going to be poor, right? So external refers to a high volume center where it has been, the index operation has been performed in some other center. So these are basically unfavorable. Some other unfavorable, basically end fistulas. These are favorable points. Those arising from leakage through a duodenal stump after cholegastrectomy. And these stumps usually do heal. You give this patient adequate nutritional support and you feed this patient adequately, they would spontaneously resolve. Jejunal fistulas, colonic fistulas, small defect fistulas, absent comorbidity, we already talked about that. But one unfavorable, you can remember a mnemonic friend, and it tells you the primary causes which could be responsible for the continuation or unfavorable aspect of a ECF. F stands for foreign body, R for radiation, I for inflammation, infection, or IBD. All three are I's. 3 I's. Inflammation, infection, IBD. Epithelialization of the fistula tract, N for neoplasm, and D for distal obstruction. So remember this mnemonic. It can easily help you to remember the common causes of a continuation or unfavorable prognostic ECF, right? Now, along with that, you basically have a lateral duodenal fistula. Like, for example, there has been injury to the second part of the duodenum, or an injury in the ligament of teeth, because that is basically a compound injury, compound in the sense, or it may be affecting the duodenum and the proximal jejunum. Very difficult to manage, right? Or ileal fistulas with a high output. The presence of sarcopenia is also a very important cause for unfavorable. Sarcopenia basically talks about a loss of muscle mass. Penia and sarco, basically loss of muscle mass. And can be assessed by the source major density. We can just talk about that, maybe assessing the nutrition of this patient. Now, there are 4 phases of ECF management. Phase 1, you diagnose, very easy, resuscitate, and stabilize. As far as diagnosis is concerned, what is not easy is there other pathology inside the abdomen. So it's not only diagnosing that some fecal matter is coming out through abdomen. That is easy. Everyone can see it. Even a layman can see it. But what he cannot see, or what you have determined, is whether there is other coexisting problem inside the abdomen, or there is a focus of sepsis inside the abdomen. So that part of the diagnosis is important. Phase 2, nutrition assessment and trying to bolster up the nutrition of this patient. Then the wound management. How do you manage that particular wound from where you have the fistula coming out? And then, of course, defining the anatomy. Why? because defining of anatomy is important. Only then you can treat it adequately, right? So diagnosis is what is suggestive. You have operated on a patient, he is lying in the ward, you come first post-operative day, second day, third day, fourth day. What do you find? You find this patient has got a torrid post-operative, he's an unsettled patient. He has a persistent tachycardia. He's got fluctuating blood pressure. He requires vasopressor support. Or he's got a prolonged ileus. Like, for example, old patients, they don't respond very early. Or they have some evidence of post-operative SSI. All these together or individually, they are very high susceptible patients for generation of ECM. So remember that. Any SSI, prolonged ileus, or a torrid post-operative course in an unsettled patient, these are all highly susceptible for the occurrence of ECM. Lab investigation, we'll just talk about what the lab investigations are. Radiological investigations, what are usually required, we'll again refer to them when we talk about the diagnosis, but at this present moment of time, two things are required. One, a radiological delineation of the fistular tract, and number two, trying to identify some other internal pathology, which can be done with the help of CCT. You're trying to look for undrained collection, or undrained abscess, or for that matter, any interfistulization or communication in between. Fistulogram, why? Because that will tell you the location of the fistula, the multiplicity of the fistula, the length of the fistula. It tells you there is distal obstruction. It tells you the continuity with the bowel, any accessory tract, and that can always be combined with the barium. What else can be done in these patients is the enteroclysis. By OGD, you can push the dye directly in the jejunum. It can tell you about the proximal part. The distal part can be have the fistulogram. Combined with the enteroclysis, you can have the proximal. So you can easily add 2 and 2 together, and then of course you have got the complete, almost complete picture. What about the laboratory studies you're talking about? Number one, very simple, get the WBC count done. Why? In the early stages of infection, we all know you got to increase polymorphs. But what you have to remember is that in the late stages of increasing sepsis, the polymorphs will be below normal, right? They decrease below normal. The sodium potassium chloride levels are expected as expected because they're lost in the effluent, so there has to be a decrease in them. What about the biochemical marker in the form of albumin markers, the globulin, the total proteins, and CBC? Why CBC? Because it tells you about the anemia. Why albumin globulin? Tells you about hypoalbuminemia. So these two are important markers as far as the general nutritional status of the patient is concerned. But what is perhaps more important and more specific is the serum transferrin level. You know the level between 170 to 370 milligram percent, and if you have anything less than 200 milligram percent, that is a low level. And these are basically predictors of poor healing. So the serum transferrin level is probably one of the better, I wouldn't say an exact marker, it's a better marker of telling you about the nutritional status of this patient. Serum C-reactive protein levels may be elevated, but then this is not the only instance where it could be elevated. It's not only because of poor nutritional, it could even be raised because of inflammation or sepsis, right? So if you look at the pros and cons of serum nutritional markers, the three markers that are commonly used, the albumin, transferrin, and prealbumin. I said earlier, probably transferrin is the best one. Why? Because albumin and prealbumin suffer from the cons, that will be the disadvantages. Albumin has got a half-life almost 20 days. As decreases in infection, hepatic failure. Similarly, the prealbumin also, although it has got a shortest half-life 2 to 3 days, but it is the levels can be altered because of a number of pathologies, and that is why probably transferrin with a half-life of 8 to 10 days is better marker among these three. It is the best. Why? Because it responds more rapidly to changes in protein status, and levels are directly related to the mortality, the closure rate, and predicting the outcomes after surgery. That is why we still stick to transferrin as a nutritional marker in patients with ECM. Right? Now, how do you assess the nutritional status of a patient? You have to assess the nutritional status of a patient. We all know, we all have seen these patients in and out of the hospital. We see them regularly in the OPD. That these patients, lean and thin, you can see all the ribs sticking out. You can see the bones sticking out. So how do you assess the nutritional status of this patient? Now, for that, the standard which has been suggested is a nutritional focused clinical examination. This is basically an examination which is just focusing on assessing the nutritional status of a patient, and has been recommended by the American Society for Parenteral and Enteral Nutrition, that is known as the ASPEN, Aspen guidelines, right? It has got 1, 2, 3, 4, 5, 6 parameters, and very easy parameters, all almost bedside parameters. Insufficient energy intake. This will basically be calculated on the history base of this patient. Intake of less than 50% or either equal to less than 50%, and that is over a 5-day period, more than 5 days. So that would be called a severe acute. That will be acute malnutrition. But the same thing occurring to a range of 75% and over a 1 month would now be known as a chronic malnutrition. So basically, based on that history, you can easily, because the patient has come to you, so you basically have to rely on the history. You cannot calculate exactly how much food you've been taking or taking. So you have to rely on the history. Number 2, the weight loss. The dry weight of the patient has to be taken, and it has to be related to the standard for his age and build. So you take the nomogram chart for that age and for that build, compare it, right? Compare it with the Indian population. Don't take the European population, right? That's very important. Loss of muscle mass. And how do you do that? By just tweaking a MAC, that's a mid-arm circumference, right? Or a bioelectrical impedance analysis. So MAC or BIA are two very good methods of judging the amount of loss of muscle mass. Loss of subcutaneous fat, how do you see it? Triceps skin fold, right? That can be measured. What cannot be measured, but which is very evident, are the hollows and dark circles in the orbital region, the obvious depressions between the ribs, and the prominent iliac cells. That can easily be seen. The patient comes in, you easily notice all these things, right? But what you can measure is the triceps skin fold, compare it with a nomogram chart. Then the localized and generalized fluid accumulation. These patients have a tendency for developing edema. Edema all over. It can go even up to general anasaka. The develops on the face, the abdomen, the extremities, the scrotum. You can see them, right? You have seen these patients with poor nutritional status. And the pitting 1+, 2+, 3+, 4+ is basically graded on how much degree of pitting is possible over the tibia. If you have 2 millimeters, it's 1+. Similarly, 4 millimeters, 6, 8 millimeters, it goes right up to 4+. So that's the depression. You measure the depression amount, and that gives you the range of characterizing or classifying the fluid accumulation right from 1+ to 4+, right? Diminished functional status that can easily be done by a dynamometer, and that looks at the hand grip strength. That's not a very costly instrument, easily done, right? So you have to have at least 2 of these 6 characteristics before you can diagnose malnutrition. So out of these 6, if you got 2 positivities, you can say this patient has got malnutrition, right? And if 2 or more characteristics are met, the malnutrition can then be categorized first by severity and further by acuity. So first of all, you have to have 2 positives, and then you can say whether it is a severe or it is acute or chronic, right? Okay. Now, the anthropometric measurements of mid-upper arm circumference, they are more or less accurate. They estimate the body muscle mass, right? And where do you measure it? Only in the left arm. Don't measure the right arm. It is characteristic. It is specific. Left arm at the midpoint between the tip of the shoulder and the tip of the elbow. That basically the olecranon process and the acromion, right? So that mid-upper arm circumference is used for the assessment of nutritional status. Bioelectrical impedance is nothing but basically passing a weak electrical current to your body, and it is indirectly but a reliable estimate of the body composition. As we said, is specific for nutritional status and for the clinical outcome. That has got a direct relationship to the nutritional status and the clinical outcomes, right? Now, why is there muscle mass and malnutrition loss? Why is there loss of muscle mass and nutrition? Okay, you say, yes, he's losing weight, but can you know why he's losing weight? Can you understand he's losing weight? Now, whenever there's severe nutritional derangements and stress, the first thing is there's a decreased glucose concentration in the body. The body wants glucose. Why? Because that is the main substrate for the energy requirements of the body. So how does it do that? By new glucogenesis. And how's that? By increasing the release of free fatty acids. So adipocytes are broken up and there's a release of increased fatty acids and ketones. Ketones are burned at this particular point, right? They're used for the primary source of energy. So instead of glucose, now ketones are providing the source of energy. They are the primary source of energy. Along with that, what is? Along with that, it's also brings up. That's also glucose, and it looks like glucose. What is the
monocytes are also breaking down at that time, and they are basically transported for what? For hepatic neoglucogenesis. So the proteins are being released, right? So amino acids and the fatty acids are both being broken down. At the same time, the acute phase proteins are being produced by the liver. So as a result of these inflammatory cytokines released there and the acute phase proteins, the muscle degradation is basically occurring and it is halting myocyte repair mechanism. So it doesn't allow new amino acids to build up more muscle. So there is a loss of muscle mass, right? So the lean muscle tissue and overall skeletal muscle stores are being depleted. Right. So what are the management principles? You can remember the SNAP is also given Love and Bailey. It is basically easy to remember SNAP, but you can remember SNAP. Why? Because there are two S's to it: the sepsis and the skin protection, N for the nutritional assessment, A for the anatomy of the fistula, and P is the planned definitive closure. Once you know the anatomy, then you plan the definitive closure, right? Especially in those cases where the fistula fails to heal spontaneously. Now, before you jump onto SNAP, you have to do two other things. Number one, you have to recognize the fluid resuscitation and the problems with the fluid electrolyte balance, right? So, the fluid management and fluid electrolyte balance have to be taken care of before you are in concurrently with the elimination of sepsis and skin protection, right? So, it's not me first or you first. It's basically occurring at the same time. You have recognized what is being lost from the body, the dehydration, the electrolyte abnormalities, and the amount of fluid being or the amount of fluid coming out from the fistula zone. Right? Then you have to look for sepsis and skin protection. So this is basically a guideline how to manage a resuscitation. Now, resuscitation, we all know that you have to manage the aggressive therapy has to be carried out, the electrolytes have to be assessed, and the replenishment. The acidosis have to be taken care of, and then of course fluid factors, and for that you have to have a 4 to 6 hourly assessment. 4 to 6 hourly since I said 4 to 6 has to be out. That is so. Somebody has told me my mic was open. Nutritional supplementation has to be done as per the regulations. We have a supplementation of 3,000 calories, which is basically slightly more than the average requirement of 2,000 calories. You'll have a significant reduction in mortality. We understand that. Now we understand that we have to nutritional support. But then comes the method how you do it, either as a parenteral method or as a enteral method. So parenteral nutrition, look at the parenteral nutrition. Basically, it may be required in which patients? A patient's got a proximal small bowel, right? For example, proximal jejunal fistula, a gastric fistula, a duodenal fistula. A patient's got a very high output fistula. In the initial period at the onset of ECF, the fistula output may be very, very high, right? Initial discontinuation of oral intake is recommended at that point of time. But because oral intake stimulates the further loss of fluid, you may like to stop the oral fluid. That is why you want to discontinue oral intake, right? A decrease in fistula output frequently occurs with the initiation of parenteral nutrition. So you may like to start with TPN. A significant reduction in mortality. So all these are reasons enough to tell you that in this particular patient, you may like to prefer a TPN or a parenteral nutrition rather than an enteral nutrition. So how do you supply the enteral nutrition? Why do you want to supply it? it is very, very important, and it's been noted, it's scientifically shown that just giving the 3000 kilocalories, 20% of them, if we just give them enterally, they protect the integrity of the mucosal barrier as well as the immunological and hormonal function of the gut. That's very important. So that means at least 20% of what you are giving, if you can give it enterally, it would be very good for the nutrition of the mucosa of the gut, and which is basically required. Why? Because that is responsible for the maximum translocation. If the mucosa is not functioning properly, translocation of the bacteria and translocation of the contents through the lymphatic system and the vascular system into general circulation is very much there. In fact, that is one of the reasons why sepsis is propagated. If you have a distal ECF, enteral nutrition is to be preferred, basically meaning ileal. Or even if you have high output fistula, we just now said a parenteral nutrition would be preferred. But even in such scenarios, after the volume has come down, you can give this patient enteral nutrition by a nasogastric tube, where positioned beyond the side of the fistula, what is known as fistuloclysis, right? So basically, you're delivering something into the distal limb directly, either per abdominally or through a nasogastric tube. So the fistula is opening, you put in a tube which is maneuvered into the distal limb, and then you start giving this patient nutrition through that particular tube. So you're basically delivering the nutrients into the distal tube, right? But what has to be remembered is that there should be at least 4 to 5 feet of distal small bowel remaining without interstitial obstruction before you can afford to put something into the distal bowel. Number 2, patients with chronic small bowel ECFs may need additional supplementation of what? Copper, folic acid, and vitamin B12. And that is why, to sum it up, it's always better to start with a combination of parenteral and enteral nutrition and later on shift purely to enteral nutrition. But you have a patient where the patient is not able to take enteral nutrition, he still is on parenteral nutrition, but the patient cannot afford to be in the hospital, or he wants to go back to home. So how do you do it? Basically, you don't want to have a TPN at home. It's very difficult. You all know that the TPN is a very cumbersome process. So for that, what we have is basically a HPN. Now, before I come to the HPN, you just talk about the difference between TPN and TN and fistuloclysis. The only thing which is problematic with TPN, apart from the fact that it's a very, very costly affair, the high cost, it is the increased chances of catheter infections and sepsis in general, and increased liver dysfunction. Two very important cons to the TPN. It's a problem. These are basically problems and disadvantages of TPN. That's why you cannot afford to keep a patient lifelong, or for extended, I wouldn't say lifelong, for extended period of time on TPN, right? It would decrease the effluence 30-50. Again, agreed. It will give a nitrogen balance problem. But then these are also available TN. That is enteral nutrition, total enteral nutrition. You have weight gain, you have positive nitrogen balance, but slower, no doubt about that. Less infection and better immunological function, the gut flora is better maintained. That's why the immunological function are better maintained. And decrease amount of bacterial translocation. That is what we want in this patient. And the cost is low. That is why the main reason basically is the maintenance of the gut flora is perhaps one of the major reasons why I should always shift to TN as early as possible. Right? Now, the fistuloclysis, especially in patients with TPN-related sepsis, liver dysfunction. These are the patients where, and the patient is still high output fistula, and patient is not able to maintain TN. There you can afford to combine it with fistuloclysis, right? And I said earlier, the catheter is placed in the efferent limb for replenishing the amount of effluent. So what is HPN? Basically is home continued nutrition, right? So when you give home parenteral nutrition, it is something which resembles a TPN. What is different? It is stable for 9 days when refrigerated. That means solution, just like a 5% dextrose bottle or a dextrosaline bottle. Similarly, the HPN comes in one single bottle as opposed to TPN, which has to be spaced out in number of bottles. The fat solution is different, the protein is different, the other fluid chloride is different. So basically, you're talking about different bottles for a TPN. Here it is everything in one single bottle or two bottles, whatever, everything mixed together, and it has got the daily requirement of protein, calories, fluid, nutrition as required or as was there in TPN, right? So equal to the parenteral nutrition solution, right? The difference is that home solutions, they would have this in a single plastic container instead of the separate containers for TPN, and it is basically vital condition therapy and easy. It's very easy to administer. right? So you just got 1 or 2 bottles, simple bottle, just like 5% Dextrose saline, just run it, right? And basically, when you're pushing a patient on HPN, a patient ECF, you're basically concerned with what? You have to greater provision of protein. You try to push more proteins in the body, more frequent nil for oral status, and a goal for future surgery. Now, nil status would basically depend upon the amount of effluent. If you find too much effluent, then you like to restrict the oral for some time, put the patient more on HPN, and then. So basically, it's a fluctuating kind of a therapy which can easily be continued in the home without wasting, without incurring the cost of the hospitalization and the high cost of TPN, right? Right. Now, this is basically just telling you, you can look this up in any of the books. It's just talking about the basic requirements, the water required of 1 ml per kilocalorie per day. You all know the sodium and potassium requirement. This has to be memorized. If you don't, you have to remember it. Almost 80 to 100 for sodium, potassium 75 to 100. Magnesium 1520 and calcium 1520. Just remember that. It's easy to remember. That's why these figures are put there. Sodium is probably higher at 120 milliequivalent, but you just remember 100, 100, 20, 20. That's easy to remember, right? Calorie and protein requirements. Basically, you require 25, 30 kilocalories and severe stress almost at 40, 45 kilocalories per kilogram per day. The protein calorie, the non-protein calorie to nitrogen ratio is again important, and you have to have for maintenance, it is 200, 300 is to 1. Severe stress is less than 100 is to 1, right? Standard general purpose TPN solution, glucose 75, amino acid 20, and lipase 30. But what is important is the supplementation has to be given over a period of time with what? Fat soluble vitamins. Why? Because fat is not being absorbed, especially in a more proximal fistula, right? Where the distal part of the ileum has been circumvented or has been surpassed or it has been bypassed. Vitamin B12 is a terminal ileum bypass. Vitamin C. So these three vitamins are important. Fat soluble, B12 and C. Fat soluble, we have all the 4 vitamins, right? Then magnesium in high output fistulas and zinc in high output fistulas are again required. So you have to supplement these, right? Now, if we look at the enteral nutrition, what are the rules for that? Number 1, oral, nasogastric, feeding gastrostomy, feeding jejunostomy, and distal limb tube feeding with as fistuloclasty. We just talked about that, right? Now, high rates of feeding should be avoided. Remember that when you're giving this patient, don't try to shove everything in a short period of time. What's going to happen? High osmolar diarrhea, and the patient will lose more. And this diarrhea is basically talking about what? The effluent increases. The effluent increases. The patient is not going to pass diarrhea in the strict sense of the term. You're basically what's happening in this patient. What's happening is hyperosmolar diarrhea, right? Prefer elemental diets, which are pre-digested diets, basically non-residue balanced diets with protein components reduced to the basic element. So basically, giving pre-digested food is always better, or is better when you're giving a enteral nutrition, and you can easily make an enteral nutrition solution just by basic things available at home, and you get a whole nutrition chart for that, and we'll not be covering that at this point in time. The next thing which is very important is the source control, and that is very, very important. How do you control this source? Identify the site of sepsis is very important. CCT helps you to identify the site of sepsis, right? And then what can you do? Once you do a CCT or ultrasound guide, ultrasound identification, you can go in for radiological guided drainage, either CCT guided or ultrasound guided drainage of that particular abscess. If not possible, then you go in for an operative intervention. That should be a last resort, however, right? So why? Because that operative intervention is going to be highly morbid and very mortal, right? What about antibiotics? It should not be prophylactic. It should be therapeutic, broad spectrum, or if possible, culture sensitivity based, and should be for not for a maximum time, but minimum time possible until the infection be eradicated. Don't continue that once the culture sensitivity becomes negative, right? What about the influent management? Fluid just keep coming on and on and on. So one, you have to neutralize the acid. And how you do that? By giving PPIs. Until the pH comes more than 6 and effluent volume is less than 1 liter per day. So point number 1, that is the first thing to be given in this patient who has got a ECF and is passing or is having a lot of effluent in the range of about 1 liter per day. Clinical efficacy of any therapy for ECF has got 3 basic endpoints. Number 1, the volume. Number 2, the time. And number 3, rate. Volume of what? The effluent. Time of what? Closure of the ECF. Rate of what? Fistula closure. So these are the 3 endpoints by which you can judge any kind of therapy. based on these three. So volume, time, and rate. Okay. So if you have to have decreased amount of effluent, you can use stool bulk binders. You can use antiperistaltic drugs, atropine-like drugs. You can use anti-secretories, right? What is advised is or debatable is somatostatin and like drugs. Now, somatostatin is basically an all-round depressor of the intestine. It decreases all kinds of secretions, right? But the problem with somatostatin is it has got a half-life of only 1 to 2 minutes. The role is debatable. The role is debatable, right? So, octreotide, which is basically a analog, is beneficial in the respect that it's got a half-life of 113 minutes, almost 2 hours, right? 113 minutes. And normally used in the range of or in the doses of 50 to 100 microgram subcutaneously 3 times a day, and should always be tried initially for 3 days. That's 72 hours, right? Now, if you find it to be beneficial, it's showing decreased amount, then go ahead and use it for at least 7 to 10 days. But when using octreotide, remember, it always leads to increased blood sugar. So basically, it should always be under regular RBS monitoring, random blood sugar monitoring. Okay, so complications of increasing blood sugar, headaches, and gallstone disease are all known with octreotide. But as I said earlier, somatostatin and octreotide have got a debatable role. Some people may agree to it, some may not agree to it, and that is why basically the meta-analysis are required. So what does meta-analysis say? 3-day trial of octreotide. If the fistula output is reduced in time, as I said earlier, continue. But what is documented? It does decrease the time for fistula closure. That is documented. It increases the closure rate. That's what we wanted. But look, the last one, no significant change in the amount. So how are you going to judge the efficacy of octreotide? That's the main problem. That's the main problem. So why? Because you're looking at the efficacy of octreotide for 72 hours. What are you looking at? The amount of or the volume of effluent. If that's not going to change, not going to change significantly. Last one, no significant change in the amount. So if that is not going to change, you would or would not like to continue the octreotide. So you may continue the octreotide under the assumption that it's probably going to help for 7 days, 10 days, and then hope for a decreased time for fistula closure and increased closure rate. Right? Now, decreased amount in high output types, again, the other things that required, we are talking about what we're talking about. What else can be done? Oral intake, balanced isosmolar glucose. The more hyposmolar you give, the increased amount of effluent. So once the patient is on enteral nutrition, you should select enteral nutrition which is isosmolar glucose. You should use stool binder foods like bananas, potatoes, white bread, milk products, caffeine, etc., etc. Restrict the amount gradually. Try to look for effluent gradual. Don't expect it's coming out from 1 liter to 200 in one day. That won't happen. It has to be gradually graded. It will come down gradually. And you can use antidiarrheal agents, either codeine or loperamide, in addition to the antiperistaltic agents, right? Loperamide is probably better than codeine. Why? Two reasons. One, loperamide causes less sodium and potassium loss. That's one. And number two, it causes or it leads to fewer side effects and sedation and fat malabsorption. These are side effects which are there with codeine. That is basically not there with loperamide, right? Okay. Now, once we come to that, now we start the definitive treatment. Disease treatment, if required. When is it required? When the index disease was something which was there, which is causing the fistula formation. Like, for example, a primary intestinal disease. Like, for example, tuberculosis, one of the very common causes. Malignancy or IBD. So, probably you cannot do much about malignancy if it is given as a spontaneous thing. Of course, you can go ahead and treat the malignancy like surgical excision or whatever. But what two things which can be treated to a certain extent could be tuberculosis. You start the anti-tubercular therapy in that particular patient, where you suspect that this patient has got tuberculosis responsible for the fistula, ECF, persistence of ECF, or the patient has got Crohn's disease, the two common causes for persistence of fistula. In Crohn's, we all know the treatment is enumerating the drugs required: 6-mercaptopurine, cyclosporin, infliximab, which is anti-monoclonal antibody, steroid, and of course the standard backbone, that is the mesalazine. Both for the ulcerative colitis and Crohn's, they use Mesacol, or use long release or persistent release of Mesacol tablets in the form Pentasa or Roasa. These are basically prolonged release tablets, but the basic salt is the same, mesalazine and mesalamine. So basically, you have to treat the cause. At the same time, you have to protect the skin. How do you protect the skin? use barriers. And the basic barrier could be in the form of ointments, it could be in the form of sprays, it could be basically in the form of films. But what is the basic material in them? Number one, all of them would be containing zinc, right? They would be containing petrolatum. They could be containing silicon polymer like dimethicone or other skin sealant. So whether you're using a cream or using a barrier or using a powder, all of them would be basically concerned with what? These three or these four important substances: the zinc, the petrolatum, dimethicone, and skin sealant. All of them have this as the basic material, either one or more, right? So basically skin barriers are very important. Whenever you're pouching a patient, you have to apply a skin barrier, otherwise the skin will be eaten away, as you call it, right? What else can be done for the wound? So you have you have treated the primary disease, you have tried to decrease the effluent, and still you want to do something else, you want an early closure. What else can be done? A negative pressure therapy. Now look at this negative pressure therapy. When we're talking about the open abdomen, we're talking about what? Pressure of 150 millimeters of mercury at that time. Now what has been advised in these patients is that you have to use almost 350 to 600 millimeters of mercury just under atmospheric pressure in the range of 700 to 760 millimeters of mercury. You all know that atmospheric pressure. So basically talking about pressure which is subatmospheric in the range of 350 to 600 millimeters of mercury. But nevertheless, what is important is always start with 150 to 200 millimeters of mercury. Now, does it help? Yes, it decreases the output almost 10 times. 10 times. It decreases the output. It increases the closure rate. It shortens the closure time. These were the endpoints we wanted. These are endpoints. The rate, the amount, and then the basically the rate and the time. The three things important, right? But one thing is important is that they also lead to new fistula formation to the tune of 4 to 4.5%. So this is a new fistula formation, right? So this is basically the conservative treatment. Now, once you carry out this conservative treatment, you hope for a spontaneous closure. Does it occur? Yes, it does occur. And it has been documented to be occurring in almost 15 to 75% of patients, right? The closure time documented is about 4 weeks in most of the patients. A further 10% would close after more of 2 months. That means 8 and 4. That means 12. Right? So 12 weeks. So we have 4 weeks or 12 weeks. In one, the closure time is 4 weeks. 10% would be closing in 2 months. Okay? Now, I have waited long enough. And now I want to operate on this patient. What do? I have to see for the time. When should I operate this patient? Post-operative recurrence rate has to be considered. The mortality has to be considered. And then the time is to be considered. First of all, let's look at the recurrence rate. The recurrence rate is almost 34%. That means out of 100 patients of ECF who are being operated, 50 to 34% of them would be having a recurrence. Exploration is occurring before 12 weeks, 3 months, 28%. You wait for more than 3 months, 15%. That means the longer you wait, the better it is. The mortality is again important. Less than 6 weeks, 20%. After 6 weeks, 11%. That means if we operate on this patient after 6 weeks of ECF formation, the mortality would be towards 11%. But the problem is when to explore. So based on this, when to explore? 12 weeks, 6 weeks, when to explore? The best is 4 months to 12 months. See this, not weeks, it's months. And maximum recommended period is 6 months. And there are a lot of studies available. This is basically institutional practices. Look at these. 8 months, 4 months, 12 months, 6 months. So basically the average is around 6 months. That's why I said that if you want to operate on a patient with ECF, wait for about 6 to 12 months, right? What are the problems, surgery? Why do you want to wait for such a long time? The patient has ECF, operate on this patient tomorrow. Why not? The patient will having a major problem. I'll like to operate tomorrow or within a week. He'll be basically would be rid of his problem. Would that happen? No, absolutely not. Why? They're basically adverse factors working in that patient. And they have to be identified. If there is an abscess, it has to be drained. You will have to create a stoma by exteriorizing a bowel. This patient had, let's say, a jejunal seal. You had repaired the jejunum, and now what's happened? It has leaked inside. What do? You basically exteriorize it. Most common is you have an enteric perforation, a typhoid perforation. It leaks. You don't wait for it to subside. Don't do that. Basically, just go in and bring that bowel out and externalize it, that probably may save the patient. So creating a stoma, externalizing the bowel, if the patient got an abscess, drain it. Or create a controlled fistula instead of uncontrolled fistula. Because when you're extracting the bowel, you'll be creating a controlled fistula. And whenever feasible, resection of the fistula with restoration of GI continuity is to be performed, but then that would be working only after 6 months. A patient conventional fistula without any adverse factor. Now these adverse factors in the form of sepsis. Adverse factor, patient is stable, is free from all sources of sepsis. That means stable basically means what? Cardiovascular and pulmonary stability. Free from all sources of sepsis. He can withstand the resection procedure. Technically, it's feasible to do it. And at the same time, when I'm doing it, I would not be injuring the other part of the bowel and other part of the structure. That has to be ensured. If all these things are there, only then I'll go ahead and do a surgery. And what surgery are we going to do? Basically, I'm going to explore, I'm going to resect, and I'm going to re-establish the continuity. But then only in those patients I would be having a good result where the patient without an adverse factor was taken up for surgery. Right? So basically that is very important that you have to look for. Now the newer trials are available. Instead of just going ahead and doing surgery, you've got a very small fistula, you're waiting for it to close down, and despite the fact that the patient already had 3 months or 4 months, it's not closing down. I can use a fibrin glue or plug. I shove something inside. Otherwise, the patient passing normal stools and bladders, everything, he just has a small opening through which a small amount of fecal matter is coming out. I can afford not to operate this patient. I just put in fibrin glue or plug. Or I can use a polygalactin plug in combination with a fibrin glue, right? Or I can use an autologous platelet-rich fibrin glue. So these are basically just plugs and glues designed by either gel foam, polygalactin, or fibrin. And these can either be percutaneously into the hole, or I can even do it endoscopically guided insertion, right? Now, coming to the last part, and that is the fibro or enteroatmospheric fistula, a term which has been coined recently. Recently, I would say about 10 to 15 years back. Initially, there was no such term. And basically, if you like to define, see this figure. See this figure? The whole of the bowel mass is outside. It's not one single bowel. The whole bowel mass is there. And you find a opening out here. Does it have any skin anchorage? It doesn't. There's no anchorage of the skin. So, in strict terms, you can't call it a fistula. How can you call it a fistula? It has got to have an epithelial surface for defining a fistula. That's not there. So, basically, the definition is occurrence of enteric fistula in the middle of an open abdomen. This open abdomen, middle open abdomen is called EAF or enteroatmospheric fistula. When you have a whole mass with the defect and exposed to the exterior without any skin margin to the fistula. Right? This is the most challenging and feared complication. Why? The results are very, very poor. You really require a high level of surgical expertise, a high level of surgical knowledge, and basically acumen for dealing with such problems. Right? You want to look for spontaneous closure? Don't look for spontaneous closure. It's not going to happen. Just like in ECF, spontaneous closure would be happening in 50-75% of patients. Here it's not going to happen. Almost impossible. So you have to go in and do something in these patients, right? Now, if we look at the epidemiological figures of EF, we have figures of EF as opposed to ECF. We don't have figures for that. Trauma patients, 2-25% will be developing a EF, right? Abdominal sepsis, 20-25%. Infected pancreatic abscess, 50%. That basically means what? 1/4 of trauma patients, 1/4 of abdominal sepsis patient, almost half of pancreatic necrosis would basically having what? Excuse me, EF. And usually, when do they occur? After the first week of open abdomen, but they can occur at any time in the hospitalization, especially patients requiring many months of open abdomen. OA stands for open abdomen. Okay, you have open abdomen, you do a laparoscopy in a patient, and we talked about the laparoscopy and the methods of covering it. Basically, those methods may or may not be adequate enough to prevent the formation of EF. Obviously, they are not in 1/4 the patient. 1/4, almost half this patient. And occurring when? In the first week of OA. The recurrence after spontaneous sealed EF, which is a rarity, the recurrence is almost 90-33%. That means almost 1/3 are going to recur again. The mortality rates of EF is around 42%. So almost 50%. Almost 50%. That means the patient who develops EF, half of them are going to die. 40% of them are going to die. So it's got a high mortality rate, right? What are the causes? Laparostomies, we all talked about that. Damage control surgery, we all know that. Because in damage control surgery, you got only one basic aim. Basically, what is damage control surgery? Damage control surgery is basically a surgery where you have to stop the bleeding before it kills the patient. That is damage control surgery, right? Interstices can wait for further time. Not for days, but yes, you can wait for a couple of hours or say 1 or 2 days. But bleeding hardly gives you minutes, hours. It doesn't give you minutes and hours. So basically, damage control surgery is preventing or taking care of the damage to the vascular compartment. The patient, whether it's the heart or is the blood vessel, whatever, right? Or it is a primary pulmonary problem. So these are basically damage control surgery, which are going to kill the patient immediately. That is damage control. You want to control that damage. Decompressive laparotomy in any patient where there is an increase in the intra-abdominal pressure. Why? Because there is essential bowel edema. Acute abdominal sepsis with severe bowel edema. Why? Because there's always a chance of having a burst abdomen in these patients. Burst abdomen in these patients. Elective surgery, complication of leaked anastomosis, very, very common cause. Like, for example, enteric fistula. Fortunately, we are getting less patients with typhoid coming with burst abdomen, typhoid fistula, typhoid perforation coming with a burst abdomen and EF, which is perhaps one of the commonest cause. Typhoid perforation, one of the commonest cause. Leaked perforation after surgery, one of the commonest cause for EF. Re-leak and repaired perforation with sepsis. So these are basically the causes, some of the causes, right? So what are the principles? Recognize it. Very easily recognizable. The whole bowel mass in front of you, you see a fecal current coming out. That is recognized. Stabilization. Can I stabilize the patient? At least I have to try. Anatomic definition has to be done in these patients. I have to define which part of the bowel. The whole thing is one jumbled mass. How do you see where what is being or what is problematic in this patient? So anatomic definition is important. Temporary care in the form of preventing further injury of the exposed bowel. I have this injury in front of me. I have this bowel mass in front of me. There is one opening. Fecal mass coming from there. I at least want that there should not be a second or third opening. So I'm going to limit. I try to limit that. And definitive surgery whenever feasible. Now, whenever we have EF management, all features discussed in closure difficult I do. Remember the laparostomies lecture? So all those procedures would, if they are done in optimal. When we talked about the laparostomies, we have talked about how to manage those abdomens, right? So everything or one or more of those should be at least applied to this open abdomen. And that would help you. Why? They would prevent the formation of a EF. So use one of those procedures which you already discussed in the abdominal closure lecture part 2, right? Now, the problem of effluent control and preventing resultant additional EF and skin protection. That's very important. I just not told you. I don't want a second opening. A second EF would kill the patient. Multiple openings, absolutely 100% mortality, right? So I don't want that. That's one. Number 2, if possible, through this opening, under guided, I can put in a catheter into the distal limb. I can carry out a fistuloplasty. Number 3 is a floating stoma. What is a floating stoma? Floating stoma is basically a stoma which does not have any skin anchorage. No skin anchorage. This was a floating stoma. This was a floating stoma, right? So it doesn't have any skin anchorage. Dam of the EF from surrounding bowel. Separated from the surrounding bowel. Try to do it. And negative pressure wound therapy for the remaining wound is perhaps one of the best options available. A floating stoma, dam of the EF, and negative pressure for remaining wound. And for that, you have to have very large stomal bag. Look at this. This is basically one of the pictures I picked up from the net. This is basically in the Asian Journal of Surgery. This is basically floating stoma. See this plastic bag out here? It could be a Bogota bag. We talked about the Bogota bag, remember? The Bogota's gap, which could just be made, the Bogota gap bag can easily be made by a Euro bag. Cut it off in between and stitch it to the surrounding. This is being stitched to the surrounding. Make opening out here. What is this opening? This opening is where the fistula is there. And over that, you pick a ostomy bag. So basically, the ostomy bag is not fitted over the skin. Is it? No. It's being fixed over what? Over this bag. That's why this is a floating stoma. Right? Now, what else can be done? What else can be done is to this bag, I can attach a negative pressure. So this is a vacuum aided closure to this bag. So if I attach a negative pressure or NPWT to this bag, this will basically a fistula. Now I can also put in a tube here and attach this also to a negative pressure. So then this will become a tube bag. So I've got 2 negative pressures working. One over the bag. This will be helping in what? By closing or approximating the skin edges. So this is trying to close the skin edge and trying to push the bowel in. This is helping by that. And what is this helping with? This is helping by trying to close the opening or the EF. So I've got two things working. I've got working one, the varicose into the fistula, and I've got a bag here which is going to be connected to a negative pressure. So this is basically looks like this. Now what do I attach out here? I attach a nipple out here. This is a nipple which you put it on the EF. So it's just not that the tube goes simply out there. A nipple has to be fitted. It can easily be made by anything available out there. And to this nipple, see the nipple, and to this I have attached the sponge. And over that, I have the negative pressure. So a negative pressure to the Bogota bag or whatever you're covering it with. Number two, a negative pressure over the EAF opening, and these together would be one of the best methods to try to close the EAF. Right? Short of that, what else you can do is you have to wait for some time for the edges to retract together. And for that, in all instances, you have to take the course of NPW. Why? Because most of these patients, doing an early surgery is almost, the possibility is almost non-existent. You can't do it. The moment you try to enter that abdomen, you're going to kill the patient on the table. Let me tell you that. 100% you're going to kill the patient on the table. If you're fortunate enough. So what is done? As soon as the burst abdomen occurs, immediately go in. Don't wait for the burst abdomen to close itself. Remember one fact. Burst abdomen, as soon as it happens, go ahead and close it. And if at all from the leaking side, make it a control fistula. Always do that. Because those patients who come to you in a neglected state, at that point of time, never try to go in. Never try to go in. If you do try to go in at that point of time, you're going to kill the patient until the patient has been stabilized. So final remedial surgery is basically the closure with abdominal wall repair. Now, as opposed to ECF, where you just had to close the dual laparotomy, close the fistula, close it. Here, what else has to be done? Here, you have to do abdominal wall repair also. Two things have to be done. And that abdominal wall repair is in the form of either ventral hernia repair of various forms. You can have to do a CST or a mesh repair, whatever required in this patient. So it's not only closure of the defect, not a closure of the fistula, it is also closure of the defect. So it's a dual problem with this patient. That's why the mortality rate is very high. And the timing is always better, and what is my advice is safer at 6 months. But then what is important in this patient is that at 6 months, having a persistent EF maybe killing the patient rather than saving this patient. So basically, remember, probably a timing of 3 months, anywhere in between would be better. Why? The internal adhesions, they soften up, the inflammatory process subsides, and the decreases of iatrogenic bowel injury. But you have to remember that when you're dealing with this patient, a CCT is mandatory. Why? Because along with that burst abdomen or that EF mass, you have to diagnose any remaining sepsis focus inside the abdomen. If it is there, always drain it. Until you have done it, this patient is not going to stabilize. This patient will never have a quiet abdomen. This patient, the moment you try to operate on such a patient, you're going to kill the patient. So everything has to be settled in the abdomen. The inflammatory process has to subside inside the abdomen before you can afford to enter that abdomen. Right? So basically, you have to do, in salvage laparotomies, where you have, we talked about the mesh repair, and we talked about the skin graft. So remember when we talked about the laparoscopy, we said one of the methods could be that you just apply a mesh, and over that mesh, you can apply a split skin graft. Remember that? So basically, when the patient has a graft with a particular area, and you have to do a further surgery, you have to repair that right now. So how do you know that this patient is in a stable position? Try to lift the graft. Pinch it away from the underlying bowel. If you can pinch it away, be sure that you can go ahead, or you can be sure that you can go ahead and do a remedial surgery in this patient, right? Until you can pinch the graft away, this patient is not ready for research, right? So prevention is always better. We all know that. So preoperatively, what can we do? We can avoid the iatrogenic injury we're talking about. The moment you have a serosal tear in a patient, you find a serosal tear, slightly deep serosal tear, basically, it can always burst postoperatively, especially if the patient has obstruction. It can always lead to rupture, spontaneous rupture. So basically, try to close the serosal tear if it is deep enough. Every serosal tear does not require closure. If it is deep, you have to have a closure, right? Because these patients are liable to have an enteric fistula. Meticulous protection of exposed bowel and covered by means of early temporary abdominal closure techniques. We already talked about that at length in the laparoscopy lecture. So if you have an exposed bowel, do it. Like, for example, damage control surgery. You can't close the abdomen. Half of the abdominal wall has flown away in a blast injury. So there you have to cover the abdomen. So use one of those laparoscopy techniques. We already talked about that, which is the best. So basically do that. And number two, minimal handling of this patient. And what is advised is only one patient should handle it. Not that today your resident does it, next day the house surgeon does it, and day after that the intern does it. Prefer to have only one person monitoring and dedicating himself to that particular patient, and he should also be minimally handling the open abdomen. That is recommended. Why? Because that gives best result. In a scenario of bad results, that gives the best result. You don't have too much to choose from. But if it's only one person doing everything, that is probably better than too many person handling their abdomen. And you know that the saying which goes that too many cooks spoil the broth. So that is basically applicable here. So not too many patients, not too many doctors should be handling that one patient. He should be handled by only one single doctor, right? So for instructional videos, I have repeatedly shown you this. You can go to my website, or you can just go to the YouTube Prime site, and you can tag on to the videos. These lectures, 3 I've uploaded, and more would be uploaded tomorrow. I have to make the movies out of them and then upload them. So that takes some time. So you can unmute yourself if you have got any questions, and thank you for your time.